Dr. Hisham. Dr. Hisham, what about the thoughts about local injection of steroid or hyaluronic acid in the upper eyelid retraction?
Okay.
One of them.
These also are two options together with the Botox. We can correct, but it will be a temporary solution. Hyaluronic acid injection may correct up to 8 months. And we shouldn't forget that the triamcinolone injection may be associated with other complications like intractable glaucoma. You can use it, but I will not prefer. If I have to choose something from the non-surgical, maybe Botox will be the easiest and the less complicated one.
Fine. Another question from Dr. Mahdi Fandari from Tunis. He should we conclude that what are the anatomical pathology change in the inferior lid retraction, and what are the anatomical pathology change in the inferior lid retraction?
It's due mainly to the inferior rectus tethering, pulling on the capsulopalpebral ligament that is attached to the lower border of tarsus. And that's why lower retraction should be corrected by insertion of a space.
Okay.
Whether hard palate or if you would like auricular cartilage or porous polyethylene.
Okay, fine.
You see,
fine.
May I comment on that, Mahmoud?
Please.
Yeah,
please.
Lower lid retraction as compared to the upper lid retraction. In the upper lid retraction, the main problem is the muscle itself. I mean the retractors, whether it is molar, levator, fibrosis, spasm, inflammation, and all those things. Whereas when it comes to lower lid retraction, the main role is coming from proptosis. And most of the time, when you correct the proptosis, lower lid retraction will be resolved.
Yes, this is what we mentioned. If it is associated with proptosis, treatment will be that of proptosis, yes.
Yeah.
This is scleral show, yes.
Yes.
Okay, can I share my
factor, yeah.
Can I share my contribution? It's a small one.
Yeah, of course.
Okay, fine.
Please.
Okay, share. And the screen. Can you close your
No need, just share your screen and it will appear.
لا حطيت عليها.
Yes. Yes, now we can see.
You can see
your desktop. Yes, now we can open.
Okay.
You're by the sea, Mahmoud. We see you there.
See, but
Dr. Mahmoud, can you open the presentation? No, the PowerPoint one next to, yes, this one. Yes, open it. Yes, start presenting and it will open.
Okay, fine. Okay.
Yes, give it some time.
Fine.
Yes, now
are you all right now? You can hear me and see my presentation. And it should be a short one, hopefully. And it's about really singing in a different way. We think of a different kind of out-of-the-box thinking. Combined oculoplastic procedure in thyroid orbitopathy, actually, it recurred to me because thyroid ophthalmopathy has a variable problems. You have the proptosis, lid abnormality, muscle imbalance, and so forth of variable degree. But the traditional teaching is to deal with this problem in an order, like proptosis first, as you have here, diplopia, and then eyelid, and finally cosmetic workup, and 6 months or so in between. But life has shown us that in practice sometimes doesn't happen. For example, combined oculoplastic procedures are very common in oculoplastic. For example, if you have got ptosis and as well as muscle imbalance, for example, this young girl who had this kind of congenital ptosis and exotropia, and she came from Yemen, and she wanted to be corrected in just 4 days duration. And then I had to do the surgery, frontalis suspension and recess resect in the same session. So this showed me, that was 15 years back or maybe, but it showed me that there is something outside the traditional thinking. I mean, the tradition is that you do the muscle surgery and you wait for 6 months, then you do the ptosis. But sometimes we can do together and spare the patient a lot of misery and a lot of effort maybe, and a lot of cost. Also, when you have a lid mass, for example, or hemangioma or whatever for the eyelid, it's not only removing of the mass, but you have to do the ptosis as well. Okay. Now, simultaneous combined procedure in thyroid ophthalmopathy, I have reviewed a few patients I got over the 6 years period, and as regard the indication, clinical activity, look at the scores, CAS according to EU GOGO, and the type of procedure, time of surgery, complications, and the need for second interference. I give you a few examples of these. For example, a 56 years old who was hypertensive, who is smoker. This is very informative case, because this patient has got a CAS of 5 out of 7 according to GOGO, but with TSI that's high, muscle imbalance, and eyelid retraction as well. And he had peculiar no proptosis. Can you hear me very well? Okay. He has
There are some noises, but we can.
I don't know. Okay, it's not. Okay, now he has high intraorbital pressure that is very high, but no proptosis, and they call this concealed exophthalmos. And the best way is to do it is to do a retrobulsion to measure the intraorbital pressure indirectly. And this causes a significant amount of optic nerve dysfunction, and he has visual acuity down to hand movement in the right eye and counting finger in the left. Okay, and he has this picture showing that he has associated orbital orbitopathy in all direction of gaze as well. Okay, his imaging, my preferred is to do the CT scan, but he was referred from endocrinologist with this picture with MRI, and it shows that the orbit is filled of muscles. There is no fat at all, and he was wondering what you are going to do for him. And we did the, for example, the 3-wall orbital decompression in both eyes, and he had recovered visual acuity. That is good, 618 in the right, 69 in the left. Okay, but there is residual diplopia and eyelid retraction. The second stage, we had to deal with both. I did simultaneous combined horizontal muscle surgery and full thickness blepharotomy at this patient. Still, he had residual dystopia, hypertropia in the right eye, which for which I did adjustable suture, and he ended up in this kind of status. Okay, and now the second case is that a girl who came with actually she had to have the wedding after a month, and she said, I want to do my eyes to be fixed within a month. I want them to look like, and she had this bulging of the fat, herniation of fat in either case. She's a thyroid patient, she is controlled, she had CAS of 2 out of 7, and she had eyelid retraction. So in the same session, we did the bilateral transconjunctival lower blepharoplasty and eyelid retraction, molarectomy in this case. A third case of 59-year-old who is a smoker, and he had a CAS that's moderate, 5, maybe 4 or 5, and before surgery, he had two problems: the proptosis in his left eye and the severe inferior rectus tethering. So we had this, it shows him before surgery and after 2 weeks of simultaneous combined two walls orbital decompression in addition to inferior rectus generous recession. This is the him being corrected. A fourth case with 48 years old smoker, and he had bilateral 3-wall orbital decompression with fatty tissue debulking. Okay, and a fifth case with 46 years old with minimal activity score, but he had fatty orbital decompression with simultaneous 4 eyelid blepharoplasties in the same session. And this also a Saudi man who came, and they came to us in the private practice, and in a week they want to fix themselves. And it's very difficult that you plan for, say, okay, now I will do the orbital decompression, go and you come back for the eyelid retraction and so forth. So we are choosing to do both the asymmetrical orbitopathy in the left eye and eyelid retraction in the same condition. I mean, that's preoperative, and this is postoperative. The seventh case is bilateral with soft orbit. This is the soft orbit, fatty tissue mainly, and 50 years old with significant proptosis with mild moderate activity, and his CAS is 3, and he had bilateral 3-wall orbital decompression with a treatment of eyelid retraction by mollectomy in the same session simultaneously. And the last case is that a girl who had 35 years old, 33 old thyroid patient who had controlled asking of upper lid blepharoplasty and cheek lift. However, she had a significant proptosis as well, droopy eyelid and so forth. And she had all this in the same session, upper lid blepharoplasty and simultaneous brow lift with cheek lift. So in summary, I would say 27 patients undergone combined procedure in 6 years. These were muscle surgery, recession of tethered muscle, eyelid surgery, whether the arthrosis correction of or the eyelid retraction, or blepharoplasty with orbital decompression. Combined oculoplastic procedures make operating time slightly longer, but yielded very favorable outcome. A tailored, I would say, very important, tailored, individualized, or customized approach is recommended way to deal with these patients. Few cases needed intervention. 6 out of 27 also we had to do another surgery. And therefore, we conclude that combined simultaneous procedure is a cost-effective means for dealing with complicated nature of the thyroid orbitopathy patient. A team approach of various subspecialty would probably yielded more effective outcome, like the, for example, the ENT, the strabismologist. Nowadays, I do the orbital oculoplastic, and as well I do the strabismology in my cases. But of course, if we have a team of these young individuals now with strabismologist, the oculoplastic working hand in hand, probably they will get more better results. Last thing that I hope to see you in real Jordan in the near future. And I would thank you all for participating in our MEASOPRS seminar. And gracias, if gracias means thank you in Italy, isn't it? And I will be glad to hear from you any comment. Thank you.
Thank you, Mahmoud. Enjoyed your talk. Very elegant talk.
Thank you. Thank you.
Thank you, Dr. Mahmoud. Thank you, Novartis. Thank you, Dr. Leonid. Thank you, Mohsen. Thank you, Idris. Beautiful, really very useful.
Thank you, everybody. Thank you. Thank you.
Thank you, doctors and professors.
Okay.
To hear, and it was a great pleasure for us to have you here. And by
last word, Dr. Francisco.
Thank you for the last word. Now, thank you all, and I completely agree with you. So what you do is basically my basic treatment. I think that, I mean, of course, everything should be customized for every patient, but there are some particular rules that I'm not following anymore. And this is especially for disthyroid patients and for socket patients. We were always told to do it multi-stage surgery. Of course, some people will need multi-stage surgery. The problem with disthyroid patients is that not every oculoplastic surgeon performs squint. And this is why nobody wants to do the squint together with decompression. Personally, I think that vertical squint is better corrected together with decompression. Now I'm starting to do some medial rectus recessions as well, but I don't have so many cases. And for lids, of course, for cosmetic blepharoplasty, basically when you do a decompression, you improve lower lid position and you remove fat in the lower part of the orbit, mainly, especially when you do, even when you do a lateral decompression. But the preseptal, the one thing that you would never touch in a blepharoplasty is the preseptal fat, preaponeurotic fat, which is really affected in these thyroid patients. So there's no point in not removing that together with the decompression. And also for lid surgery, I think that now we always know that both muellerectomy and blepharoptomy are very predictable. For blepharotomy, it just depends how much you leave intact of the upper conjunctiva to grade it a little bit better. So you can do it even on the general anesthesia. I don't really believe that you have to overcorrect it on the table with patient on the local to get it right. So as Moses say, in some cases you have to wait, and I still do multi-stage surgery. There are patients who refuse bilateral decompression, so you end up doing 6 or 7 operations. But generally speaking, if you can do it together, I think this is better. Thank you and excuse me for talking too much. Probably.
Oh, thank you. Thank you. We have planned to put this seminar on the YouTube if we can. Anybody has got objection?
No, I don't think so.
No objection.
No okay. Objections. It's okay.
Fine. Can I ask you something, Francisco? Please. Can I ask you something, Francisco?
Yes.
Tell us, how is it going in something not related to thyroid? Tell us, hope that we have good news from Italy about Corona. Tell us, we are hoping that things are getting under control.
Okay, things are apparently not totally under control, but things are improving very well, are improving a lot. So yesterday on the 4th of May, we started a sort of, I cannot say the end of the lockdown, but we are back to some offices are open. We are starting a sort of elective surgery. So what concerns us, but shops are still closed, restaurants are still closed, but it will be very gradual because we are waiting to see what's going to happen in 2 to 3 weeks. Apparently things are bad. In Rome, they are not very bad. Northern Italy, as you probably know, they're still bad, but we used to have about 800 or 1,000 dead people each day, and now we are down to less than 100. I wonder about Iran, what's happening. It's better, I suppose.
Yeah, it's kind of settling down somehow. They have eased kind of the lockdown in here. With the very serious instructions, we have started elective surgeries too. As you said here, restaurants and not the shops, but the restaurants are closed. They can just deliver the food, but they are not open to go there. But the shops are somehow open. Elective surgeries kind of, not in general hospitals, in subspecialty hospitals. But generally, going back to work in these days, you don't see that many patients even coming to the clinic because they are still afraid of, coming out and getting exposed in the hospitals, things like that. Even us, we are scared, kind of, yeah. But yeah, the death toll is down to like 60 to 70 now each day. from like 140, now it is half. And the positivity is not reliable because we don't have that many tests to do. But what they say and what they do, it is now lower number we see. But they are expecting maybe a second surge on the curve of COVID-19. We'll see.
Okay.
Yeah.
So are we coming to Italy for MEASOPRS, Francisco?
For MEASOPRS, I mean, MEASOPRS has been cancelled and has been postponed. I mean, we decided very early. I was very instrumental in deciding that, because even if we hope, or we could hope 2 months ago, that things will be better, how many people will be happy to travel? And also it's a big meeting, so you have to decide 3 months in advance. So it's been cancelled. We have other projects. We will start a few webinars, but later on, because we knew that many webinars, there is a lot of offer. So there are other projects for the society, but so far the meeting has been postponed to September 2021. And
that was a very wise early decision. Yeah, it was a very wise decision.
Yes, and it was wise to decide it quite early, not to, I mean, people with uncertainty.
Yeah, we are struggling. We're getting back canceling the flights and hotels for different meetings up to mid-July. We had already booked. Now we have different problems with the airlines, hotels, and things like that. Exactly. But for these MEASOPRS, early, no booking.
Exactly, no booking, much better. And I can tell you that even the world meeting has been postponed.
Yeah.
So you know that. So it will be in 2022.
No meetings. Only webinars only.
Yeah, WSC virtual, right.
Okay, this is how we fight against Corona, by getting close by virtual world.
Okay. Thanks, Mahmoud, for organizing this. Thank you.
Thank you a lot.
Thank you very much. Thank you.
Thanks very much, and hopefully see you soon in person. Shake hands.
Soon.
Okay, bye-bye. Thank you, Novartis. Thank you, Ahmed.
Thank you.
Thank you.
Thank you, Ahmed. Bye-bye.
You're welcome, Doctor. Thank you.
Bye-bye.
It was an honor to have you all tonight. Bye-bye.
Thanks.
Thank you.
Bye-bye.
Al-Salem.